Welcome to the January 5th EMRAP. Jan, it's great to be here in the new year.
It's 2026, Swami. Can you believe it?
It's actually pretty unbelievable that it is now 2026. I feel like each year we start off and we're like, oh, this last year went so quickly, slow things down a little bit. But here we are. It's the beginning of 2026. And as we always do, I was looking up kind of events from the day. What happened on January 5th in other years? And this one was kind of interesting to me as a little bit of a science nerd. Back in 2005, the dwarf planet Eris was discovered, and that resulted in demoting Pluto from a planet to a dwarf planet. And Jen, that ruined the mnemonic device that I learned in elementary school for how to remember all the planets. My very eager mother just served us 9 pizzas. That's the way you remember them, right? So my is Mercury, and then Venus, Earth, and so on and so forth. But now it's like my very eager mother just served us 9. Because there's no Pluto, there's no pizzas. So I don't know. This way of remembering planets, I don't know. What do they teach now?
I don't know, and I never learned that one. So this is absolute news to me.
This is bizarre. This is not a mnemonic device that they like. What the West Coast has a different mnemonic device for the planets?
I don't know. Palm Springs Unified School District. This is on you. I just never learned it. I've never heard it before today. But maybe there's an opportunity to fill in the 9 with a blank. You can fill in 9 whatever you want into your wonderful mnemonic.
I guess so. You know, what I actually kind of am curious to hear, because I just thought this was like a universal thing that was taught in schools. I'd love to hear from the listeners, like, how did you learn the order of the planets? Did you have this mnemonic device? Did you have a different one? Let's find out. If this is like an East Coast, West Coast split, I don't even know what the international folks are doing. Do you guys even have the same planets that we have? Like, what's going on outside the U.S.? I don't know, but I would love to hear about all of it from you guys. But Jan, what this kind of brought up in my mind is mnemonics themselves. And there's so many mnemonics in medicine. Are you a mnemonic person? Do you use them to kind of remember stuff?
Here's the thing about mnemonics is that they're supposed to help you remember, but then you have to actually remember what the letters stand for. So that's often a barrier for me. But I'm not a big mnemonic person, but there are some that I do use fairly frequently. And probably the number one thing that comes to mind is mud piles. For someone, that one really stuck with me. And I think that's because every once in a while you get that acidotic patient, you run through, trying to make sure you're not missing something. And then some of the ones, you get to methanol and you roll your eyes. You're like, well, it's never methanol. I mean, there's parts that are just out there, but that's the point, is so that you always consider it. So yes and no. I have sort of a neutral stance on this one. I'm not a strong advocate, but I don't have any problem with it. I just have a hard time even remembering what the letters stand for.
Well, I think it's funny you brought up the methanol one, but didn't bring up the paraldehyde one.
Right.
When's the last time you saw paraldehyde poisoning? Like,
yeah.
I don't even know what that is. Like, what would even... Sean, before you get upset about me saying that it's not really a thing, I'm sure it's a thing. I agree. We don't see it. So I don't like mnemonics. I don't really use them very much. I will say that, one of the things that the EMRAP folks maybe don't know is that in the background, we have a bunch of production people that are kind of working to keep you and I on track, make sure the audio is good and stuff. And one of them, Tom, just typed in 2 other mnemonics for remembering the planets. I got to read these out. My very educated mother just served us nachos. I'm good with that one. I love nachos. Or my very excellent mother just served us noodles. I think by the end of our recording, Jan, Tom's going to have like 19 of these for us to choose from. So we will pick one that will be the new mnemonic to remember the planet. So I am also not much of a mnemonic guy. I agree with you. I can never remember what they stand for, so I don't really use them. But that has nothing to do with what we're going to talk about today, because we're going to dive into a case. So Jan, I have a case. Are you ready?
I am perfectly ready. My mind is open. Let's hear it.
All right, great. So I've got a 63-year-old man who's presenting with chest pain. He said it started about an hour prior to presentation. It is sharp. It came on suddenly and it goes to his back. He has no shortness of breath, no dyspnea, no palpitations. There's no exertional symptoms, although it's only been going on for an hour. And I'll admit, he didn't really exert himself very much in the hour since this pain came on. He's got no history of similar pain in the past. And he said that it's constant. It doesn't hurt more when he takes a deep breath, and no other associated symptoms. He's got a history of hypertension and hyperlipidemia. I'm going to take some of these things, the initial questions that we always ask out of it. His vital signs, he's hypertensive. He's 180/78. Heart rate is about 90. His SAT's 99% on room air, and he's afebrile. And his physical examination, aside from the fact that he looks a little uncomfortable, is completely normal. The ECG is unremarkable. So you've got all of that before you even see the patient. What are your initial thoughts? What are the things that you are thinking about when you see this guy?
Well, this is a bit of this is like a classic med student oral boards case. What is your differential of emergent causes of chest pain? So I'm running through the things. I'm running through acute coronary syndromes. I'm running through PE, dissection, the rare things, the Boerhaave's, the pneumothorax, those kinds of things as well. Does he have pneumonia? Is this an atypical presentation of something else? But you mentioned going to the back. I mean, you mentioned that obviously on purpose. So there's a historical feature that you threw out there for me that makes me want to also wonder what his wingspan is. I use that term for people when I'm wondering about Marfan's, like does he look unusually long in the limbs, that kind of thing. So I'm running through that differential. I also want to ask you one more thing, which concerns me sometimes when I see people with chest pain, which is, does he look diaphoretic? You said he's not in a lot of distress, but I want to know exactly, he came in an hour after this started, so there's something about it that brought him in. So I'm kind of trying to dissect through a little bit, through a little
very
bit.
Very good, Jen, very good.
Through what exactly brought him in 1 hour after this started, because most of the time when we feel a pain in our lives, we're not coming to the ER within an hour. So, is there something else to this that I'm missing?
All right, so he does not look Marfanoid. Let's take that one out. He looks like a normally sized person. He's like, 5'8", 5'10", somewhere in that range. He's uncomfortable appearing, and he said, I just never felt anything like this before. It didn't seem normal to me, so I came in. So, all right, we're going to give him a pass on it's only been an hour, because he does look kind of uncomfortable. He is a little hypertensive, although he's got a history of hypertension, and I like the things that you focused on. This is kind of really bread and butter emergency medicine, right? Thinking about ACS, dissection, PE, pneumothorax, all of those kind of things. When I look at this guy, the fact that he doesn't have any exertional symptoms kind of makes ACS a little bit lower. The ECG looks good. So all of those things point me away from ACS, but obviously I'm still considering it. PE seems a little bit lower as well. And dissection kind of keeps popping up to the top. Even though he doesn't have any family history, there's no Marfanoid features. We even asked him about, has anyone died suddenly of unknown causes in your family? He's like, no. So we don't have any of those kind of risk factors, but we do have this concerning story. It's one of these things that once you think about dissection, it's very hard to get it out of your mind. So based on the story that you've got here, Jan, are you going right to CT angio? We've talked about the limitations of testing and workup here. Are you going right to angio with this guy, or are you going to do some other things first?
Well, I think we're skipping over a few things here, and I do want to answer your question. I'm thinking about it, but I want to go back on the physical exam and just clarify that he has equal pulses. As soon as dissection kind of comes to mind, there are some physical exam things that I want to double check. Not that those things are 100% reliable, but I want to check the boxes. So, in terms of pulses, and then obviously we're ordering basic labs, and I'd like to look at the chest x-ray. Now, a caveat about the chest x-ray. Certainly we know in aortic dissection that it is not a perfect test. It is a screening test. We know that from the IRAD trials that the chest x-ray can be normal a good number of times. So it's not going to talk me necessarily in or out of the question that you're asking, but I don't want to skip over that step as something that could be a clue, because obviously in a big old wide mediastinum, that would push me very quickly towards CT, and a negative one wouldn't make me rule it out. But I just want to mention those things as well.
This is kind of the crux of the issue, right? We have these other tests and physical exam features that we think about with dissection, but none of them are that great. I mean, if you have unequal pulses with this story, it probably pushes you more towards dissection. But if you have equal pulses, it probably doesn't do much to push you away from it. The chest x-ray, same thing, just like you said. If you find something really disturbing, you're probably wheeling that guy to CTA yourself. But if it looks normal, you're probably not going to change anything. So we did all those things. We checked for pulses. They were equal. We got the chest x-ray. It looked unremarkable. And so we still kind of came back to, do we get a CT angio or not?
So, and then this gets to, it's a little bit similar to PE, although I don't think of it exactly like PE, which is, what is your overall gestalt in terms of how likely you think this diagnosis is? And one of the ways I kind of ask myself that question is to mirror it back to myself, which is, if I didn't get the CT angio in this patient, would I be thinking about it later? Would I be worried about this patient if I decided to skip that test? And that to me is sort of a way to reflect to yourself about how high your gestalt is. And probably in this case, it sounds like I would be worried about it if I didn't get it. I'd be wondering if I missed it. So I'm thinking this is pretty high likelihood. So probably yes, I would get it. Now, I work in a place where it's not hard to get, and I want to just, there are a lot of people listening to this think, I don't even have that option. Now I'm thinking about whether I would transfer this person, kind of a different threshold as well. But, yes, I probably would be leaning that way at this point.
Yeah, that's kind of the way that we were leaning as well. And we kind of kicked around, are there other options? Like, can you get an MRI? Well, not really. You're not in a timely fashion. A TEE, I mean, that's like one of these dreams that like, oh, I can get a TEE to make this diagnosis, and then someone's going to operate on this guy based on a TEE. Like, these things just don't really happen. So CTA is really where we have to go. But we do have a little bit of and I want to put the word new in quotation marks, a new tool to kind of help in this evaluation, which is the aortic dissection detection risk score. And the reason I say new is because it's not new. It's been around for a while. Amal and I have talked about it in the past, but what is sort of new about it is that it's getting a little bit of an endorsement from professional societies, including ACEP. ACEP included this recently in one of its guidelines.
Yes, I am familiar with it. I have heard of it. I'm glad you're bringing it up. So remind us about this score.
Yeah, so the score itself is based on just a couple of things. It really asks just 3 questions. Does the patient have any high-risk conditions? And it lists things like Marfan's and family history of aortic disease. Do they have high-risk history? So that's that chest and back pain, that radiation, the abrupt or sudden onset of symptoms. And then do they have high-risk physical exam features? Those are things that you pointed out, the pulse deficit, the blood pressure difference, the neurologic deficits. If you have a no on all of those, it's kind of like, well, why were you even thinking about dissection in the first place? If you answer yes to just one of them, this score actually says, well, you know what you could do? You could get a dimer. If you have one or less of these, get a dimer. If the dimer is negative, you've pretty much excluded aortic dissection as a diagnosis. If you have more than one of these features, then just go ahead and get the CTA. Don't waste your time with a dimer. And I think this is interesting because, again, we've talked about it in the past. We've kicked it around for a while, but the fact now that organizations are saying this is a reasonable way to evaluate low-risk patients for aortic dissection gives us a little bit of an impetus to say, oh, well, maybe I can just do an aortic dissection detection risk score and a dimer instead of getting that CT angio. So I don't know, Jan, this has been around for a while. Have you used this? Have your residents asked you, why don't we just do this instead? Is this something that you have thought about in your evaluation for these patients?
Yes, this is something we've been talking about for a while. I work at a teaching place, so it's the kind of thing that we banter about, whether or not we follow it exactly. The fact that you're saying that the professional societies have endorsed it, I think it moves it up a little on the list. The thing about this particular score, I like that it's simple. Pretty much everyone's going to get a point for the high-risk history, or else you wouldn't really be talking about the score.
Right.
So you're already kind of entering the score with a point score of 1. And then you're right. These other things that are a little more unusual, the right history or the right exam features, that gets you somewhere. So that's my one thing with the score is that you're already there with that score of 1. Otherwise you wouldn't really be considering it. I don't know. That's my experience with it.
That's the way I feel too about it. I think that's the one that brings us into consideration of this. It's where the story makes me think about dissection, but nothing else in the exam or the workup or my evaluation really makes me think that, but I can't get it out of my head. And so I got to do something. And that something used to just be going to CT, but now we're working in the dimer. And just to kind of be really clear with the dimer, if you are using the FEU units, that's going to be a cutoff of 500. If you're using DDUs, it's going to be a cutoff of 250. There is no age adjustment to this. So like the 95-year-old who you put into the aortic detection risk score, you are not going to say, oh, I can just multiply 90 times 10 and my upper threshold is 900. No, this is just a straight cutoff at this point. But that does mean that we're inserting the dimer into our evaluation for dissection, or at least potentially inserting it into there. When you look at this patient that we have, would you consider applying the score and getting a dimer?
I would consider it. I would consider it. The other thing about that 1 point, the high risk history, is that if the patient is diaphoretic and tearing chest pain, but that's the only thing they have, and they have that point of 1, would I still trust a negative dimer when it's still my leading diagnosis? So I just want to color it a little bit, is that there's different gradations of what that high risk history looks and feels like in the patient in front of you. Are they also, a smoker with pretty high blood pressure? I mean, blood pressure cutoffs aren't necessarily used in this score. So I just have to say that I still have there's some innate discomfort in terms of my gestalt measuring up with this score and how suspicious I might be. PE. However, I will say that the D-dimer literature I think it does support, which is why people are endorsing this, it does support using it in the low-risk population, that a negative one can get you there. So yes, I would consider it, and I think that that's reasonable. So did you do the dimer, I guess is my question to you. Did you do the dimer?
Right, that's the question. So if I have a low-risk patient where it's like, well, I don't really think this is a dissection, but I can't get it out of my mind, that's where I think you could use a dimer. But of course, Jen, let's just put the caveat there of we know what dimers do to workups, right? I mean, if you apply this willy-nilly to every patient with chest pain, you're going to get far more CT angios than you were before. We know that with PE. So you have to be very selective with who you're getting that dimer in. If you look at the patient, you're like, wow, this guy does not look good.
Right.
I'm not doing the dimer. Even if they only score 1 point on that score, I'm still going to CT angio. I agree with you 100%. And this is a really important point. We're not saying that you should get a dimer on everybody. If you look at the patient and you're like, I am really worried about dissection, just get him to angio. Don't wait for the dimer and then it's like, oh, the dimer's positive. Now I should go to angio. No. This is if you're really worried, skip everything, go right to angio. This is where I'm typing in my angio comments. Do not wait for labs to get CT angio. CT angio immediately. Do not pass go. Do not collect $200. I'm definitely not waiting for a dimer in that circumstance. But in a guy like this, where it's like, well, there's no real risk factors, I can't get it out of my head, I'm going to go ahead and get the dimer. So we did get a dimer, and drum roll, Jan, the dimer was negative. The dimer was low, and honestly, that kind of ruled out PE as well, or at least risk stratified it to less than 1%. It made me feel pretty good this wasn't a dissection. We actually did get a troponin, even though I didn't think this was ACS. The troponin was less than 6. That's like kind of our high sensitivity threshold to say, man, it ain't ACS. So this guy had like triple workup negative for dissection ACS PE. And so we were left with a guy with chest pain, but no real dangerous diagnosis. So we gave him some pain medication and I sent him off into the night. And I went and left my shift saying, this is the M&M that is coming around the corner, right? This is the one that's going to get me. But I'm not going to leave anyone hanging. Guy did just fine. Because I was worried about it and applied this risk score and got the dimer, I called him. I called him like a day later and said, hey, how you doing? He goes, oh, I'm totally fine. I went to work today. I feel great. And I'm like, wonderful. And you made that a follow-up appointment with your doc, right? He's like, oh, yeah. I'm going to follow up with my doctor. Sure. So at least the next day, he was totally fine.
Yeah, I'm glad you called him. I think that is another way to settle your concerns, and I like doing that. I really do like doing that. And patients love it when you call them.
Oh, they do. They do. Yeah, my approval rating just shot through the roof with that phone call.
Yeah. I think one of the other things that I was thinking as you were talking through it, which is, again, with the D-dimer, when you do send that D-dimer, you need to make that decision in advance about what you're going to do with it if it's positive. Yes. So if it does come back positive, you better be committed to that CTA. Don't talk yourself out of it at that point. And I think the other clinical question that comes up with someone who has some degree of hypertension, which this patient did, which is if you're suspicious enough to be sending them for a CT angio, are you jumping on that blood pressure at the same time to actually control it? And that's one of those practical questions that comes up. At what time when are you starting, some kind of antihypertensive agent? At what point are you suspicious enough to do that? And so I think most of us would probably restrain ourselves in someone like this who's not like clearly screaming dissection from lowering that blood pressure. But that is another discussion point that comes out that we don't have a great answer to, except, you have to just judge on the circumstance and the number in front of you and how suspicious you are. But that's another thing that we would be considering.
Yeah, if I have a really high suspicion for dissection where I'm wheeling that patient to CT, I usually will ask my nurses, can we draw up some opiates for pain control? Let's give him some pain medication before he goes. That will lower the blood pressure to a certain degree. We're never going to get ahead of the blood pressure and heart rate until we take care of the pain. So that's a quick and easy thing to do as we're going off to CT. And then when we come back, then I can start all of those blood pressure lowering medications. I might even ask them, hey, let's prepare the medications before we come back. If we don't use them, we don't use them, but at least we have them ready to go. So I think that there's a lot of nuance in there that we're not really getting into, but you've pointed this out before, Jan, and I really think it bears repeating. Once you get the dimer, you've committed yourself down the pathway to a CTA. Don't second guess yourself after that dimer comes back positive. Don't try to convince yourself that you really don't need the CT if it comes back positive. Once you've committed to getting the dimer, you're sort of going down that direction. Now, if you're ordering labs from triage and you have an order set that gets a dimer from triage, I think you can back your way out of those. But if you ordered the dimer, you're kind of stuck with the results.
And if you do have a pathway where you're ordering D-dimers from triage, try to get rid of it, because I think that is just a pit of danger.
Yes.
For me, yeah.
100%. All right, Jan, well, let's wrap this up. The big thing that I really wanted to kind of discuss and get across here is that this aortic dissection detection risk score is not new, but it is newly endorsed by our professional organization, ACEP, and it is something that I think we can start working into our algorithm for working up the low-risk patients. But if the patient's high risk, go immediately to CTA. You don't have to wait for any labs. You definitely don't have to wait for a dimer. Just go ahead and get that CT angio done.
Yep, great case.
All right, well, Jan, we will drop a link to that ACEP clinical policy in the notes. You do not have to be an ACEP member. You don't have to be a member of Annals of Emergency Medicine to access that. That is free, open access for everybody. So check that out. I think it gives you a little bit of a backing of what it is that we want to do to try to reduce a little bit of that testing. And with that, Jan, we're going to dive into our week. Of course, we have some great stuff on tap. We've got Mike Weinstock back with a risk management segment. And we've got Mizuho Morrison on talking about menopause and where our role is in the emergency department with this. And Jan, with that, let's dive in. Let's start with a couple of papers from last month's EMA.